My name is Daniela Martin. I'm a radiation oncologist. I'm currently running the radiation therapy department of Professor Chiricuta Institute of Oncology from Cluj-Napoca. And I'm joined here by two key members of my team, Roxanna Zaharia, medical physicist, and Cornel Rusnacu, RTT. Both of them are deeply involved in the development of SGRT, in the workflow, day-to-day workflow, so from the CT simulation and treatment planning to accurate day-to-day implementation and treatment delivery. So I will start with a quick overview of our radiotherapy department, and I will walk you through how we begin implementing SGRT and integrated it into workflow. And then Roxana will present the results of our analysis of SGRT implementation, the clinical and operational endpoints regarding precision, regarding reproducibility and workflow efficiency. So a few words about our institute. Our institute was founded in 1929 as an institute dedicated to prophylaxis and treatment of cancer. And this year we celebrate our 95th anniversary. In 1982 was founded the first pediatric oncology department in our institution. In 2017, we was designated as a clinical cancer center by OSC. And now we are on the short list of becoming a comprehensive cancer center within the UNET CCC network. So we provide treatment for around 2,400 patients each year. 70% of them are coming from across the country. We treat full spectrum of tumor sites, but the most frequent are gynecological, breast, lung, head and neck, GI, and prostate cancers. So, of course, our goal is to improve the quality of our treatment, and there are multiple studies that have shown a benefit of 5 to 15% for survival for patients which are treated in highly specialized center. Regarding radiation therapy, how we can achieve that improvement by strengthening the standards in dose prescription and delivery, by expanding the use of advanced techniques and in increasing treatment accuracy, and by integrating the radiobiology insights in for refining and personalized therapy. So over the past decade, SGRT has evolved from an supplementary tool to a important and core component in patient setup and in real motion, real-time motion monitoring, by increasing positioning accuracy, intra and interfraction reproducibility, safety and patient comfort, and by reducing the errors and uncertainties of the process. So all these things are essential because the success of radiation therapy depends on the administration of a safety administration of an optimal dose to offer a maximum probability of tumor control with a minimum risk of late complication. So we currently treating 160 or 180 patients on 4 Linacs and 1 brachytherapy unit. every day. We implemented Align Anti only on one machine, and we are planned to expand this thing. So we will talk in the next minutes about implementation of SGRT on this one. So for doing this, we had a lot of training, and you can see here Wesley, Irakli, and Carol, who leads our training sessions. In fact, Irakli was last year at two important events in Romania, the National Course for RTTs and the Best of Astro Romania event. So we started with left breast cancer patient at the CT simulator, and with SIMRT integrated workflow. This is a patient with metachronous bilateral breast cancer with a disease-free survival of over 10 years following a luminal B breast cancer. We try to go without tubes, but we are not yet there. So of course we try to keep a cardiac dose as low as possible, because we know that for it's an increase in cardiac morbidity of 7.4% for each 1 gray in increase in mean heart dose. So we try to keep cardiac dose as low as possible. And we did it with our first patient treated with Align RT last year. So you can see the team in the control room. Everybody is worried, then relieved, and at the end happy because everything worked out perfectly. So we have almost 1 year experience on one machine, which is TrueBeam. We treat 452 patients with SGRT. And you can see here the patient distribution by site. At this machine, the majority or the leading are patients with breast cancer, gynecological follows, CNS, lung, prostate, and GI. We will focus mainly on 3 areas where SGRT has had improvement in our activity, which is breast, deep inspiration, CNS, SABR, and pediatric patients. And if you are looking in the right, there are breast cancer patients treated with SGRT. Almost 70% of them are with left breast. And among these, near 65% are with deep inspiration, and 44% are with free breathing treatment. This is the percent because this is 100 patients, 60-40. So we were not happy with this percent. We wanted more. And we noticed that patients who manage well at the CT simulator to keep their breath hold often have difficulties of the treatment. So we try to improve this. We try to improve the patient compliance, and for this we start counseling. At the first consultation, we try to explain the patient and show the benefits of deep inspiration breath holds, and we use information materials. We organize training session with our physiotherapist and to practice deep before any procedure. We run a mock-up fraction a week before CT simulation. We encourage the patient to consistent practice at home. We set up a team, a dedicated team for patient preparation. Of course, the radiation oncologist, the kinetotherapist or physiotherapist, the nurse, the psycho-oncologist for track and address patient anxiety, and the important member of the team, RTTs, which offer consistent coaching through all the treatment. So here are our results presented a month ago on our National Congress. The patient with deep inspiration had an average reduction of 45% in mean heart dose and 55% in mean LDCA dose compared to the patient who were treated with free breathing. So we have some experience with pediatric cases. We treated over 1,000 patients on 40 years. The patients come and their parents come from across the country. Last year, during the last year, we treat 71 pediatric cases with different pathologies, you see here, and 32 of them with anesthetic support. So here is a patient of 5 years old, a boy, who had retinoblastoma. He was the first patient treated with the anesthesiology team. And to do this is necessary to have a strong teamwork. And you see here all my colleagues from different departments, from ICU, from oncology, and of course from radiation therapy. So at the first beginning of this year, we upgraded our TrueBeam to enable SABRE treatments, stereotactic treatments. You can say we put all the money on one machine. So this is the distribution of patient by metastatic sites. And we treat around 60% patient with oligometastatic disease with CNS metastasis, lung, followed by liver and bones and adrenals. So here is a patient with multiple brain metastases from a lung primary. She was treated, of course, with SGRT and with hyperarc technology. So here is the team. They salute you and wish you luck with your work. And implementing SGRT provides an important tool for our quality assurance in our daily work. And it's an important step forward for improving the quality of care delivery and the outcome of our patients. So I will ask Roxanna to come here and to present the results of our analysis regarding SGRT implementation. Thank you very much for your attention.
Hello everybody, I am Roxanna. I'm the medical physicist at the Oncology Institute here in Cluj. I want to thank my colleague for this true introduction about our institute, and now I want to move on and talk about the study we conducted on our experience with the SGRT system. The main goal of this study, the main goal of the study was to evaluate how the implementation of SGRT improved our daily practice. In order to do that, we evaluated some key metrics like the couch shifts that were applied after the CBST verification, the overall workflow setup efficiency, and also patient compliance and stability. And in the end, we also looked at the clinical impact. We wanted to have a comprehensive and practical understanding on the impact that SGRT had on our daily clinical practice. Before starting to get a little more into the study, I want to briefly talk about how we integrated SGRT into our daily positioning workflow. For our DIBH patients, we first positioned the patient after the free bleeding surface, and then we switch to the DIBH1 and we make sure that all the line RT deltas are in green. And after that, we acquire CBCT imaging verification for every patient for every treatment session. When it comes to our two treatments where we used open-face thermoplastic masks, we first position the patient's head to make sure that the head alignment is correct, and then we apply the mask, and once again we make sure that all the deltas are in green, and we move on to acquire the CBCT verification. In this study, we analyzed two main groups. One DIBH group that was formed of 20 patients, and also 10 stereotactic treatment in the cranial region. We analyzed 4 different CBCTs from different treatment sessions, having a total of 80 fractions analyzed for our DIBH group and 40 fractions for our stereotactic one. We analyzed the CBCT couch shifts because we wanted to see how close is the SGRT initial patient alignment to the real treatment position. And in order to do that, we calculated some key metrics like mean and standard deviation, and also the 50th, 90th, and 95th percentile for the translational and rotational motions, and also for the 3D vector magnitude. First, we analyzed the translational setup accuracy for our DIBH group. At first glance, we can see that our mean values are small. They are around 1 to 2 millimeters, and 90% of the fractions analyzed had an overall magnitude within 5 millimeters, showing that we have a strong positioning accuracy. The close match between the mean and median values reflects consistent performance without having significant variation between the fractions analyzed. Looking on the graphic where we represented the mean and standard deviation for the translational axis and also for the overall magnitude vectors, we see that the couch shifts applied after CBCT verification were within 3 millimeters for each analyzed axis and within 5 millimeters for the overall magnitude. And so we can say that we have a very high precision translational positioning. Following the translational analysis, we also looked at the rotational setup accuracy. Here we can see that our rotational workflow is highly stable. Most of the couch shifts applied were within 1 degree, and 90% of the fractions analyzed had an overall magnitude of within 3 degrees. On the chart, we see that our data is narrowly spread, showing constant performance between fractions, and even the highest calculated values were still within our internal tolerances. And overall, we can say that AlignRT helps us to get a very precise and reliable positioning workflow for the translational and rotational motions. In addition to the previous results, we also wanted to see how this performance holds up across multiple treatment sessions. In order to do that, we represented the magnitude distribution for all the fractions analyzed for the translational and the rotational motions. Looking at the translational plot, we can see that the majority of the fractions analyzed were within 5 millimeters, showing a very stable positioning from session to session. And in the rotational plot, we see that almost all fractions were within 3 degrees, and in both graphics, we see that the performance was consistent without having significant overdrifts. And this shows us that by using the AlignRT system, we are able to have a very reliable and reproducible position through the whole course of the treatment. Now that we see how good of a consistency we are able to achieve with our current workflow, it's important to see how much of this performance is actually due to using the system itself. In order to do that, we compared the data from our SGRT DIBH group with data from our previously tattoo-based free breathing breast setup. We had to compare with the free breathing because before installing SGRT into our clinic, we were not performing DIBH at all. What we observe here is significant reduction in the translational displacement. The overall magnitude drops from 7.4 millimeters to 3.8 millimeters with our SGRT system, and the overall deviation is cut in half across all the translational axes. But when we look at the rotational plot, we see that we do not have a significant difference in the rotational performance, and we think that that is most likely due to the fact that we use the same immobilization systems for both workflows. But overall, we can say that our performance, especially for the translational displacement, is directly linked to the use of SGRT, which allows us to get a more stable and reliable setup for our breast DIPH treatments. Moving on, let's get to our stereotactic group. For this group, we focused on patients that underwent radiation therapy in the cranial region because we wanted to see how the SGRT system would perform in a more challenging scenario where most of the patient's surface is covered by the thermoplastic mask. What we observe is very similar and constant with our previous results. The couch shifts applied were within 1 to 2 millimeters, and 90% of the fractions analyzed had an overall magnitude of 4 millimeters, showing a strong positioning accuracy. On the chart, the mean and standard deviation are narrow spread, showing that we have consistent performance for the translational positioning. Following the translational analysis, we also looked at the rotational setup accuracy. We see that our rotational performance is highly stable, with most of the values being within 1 degree. And even the 95th percentile magnitude is under 2.5 degrees, showing excellent angular control. On the chart, the mean and standard deviation are tightly grouped around under 1 degree, showing that we have very limited variability and strong reproducibility of our workflow. And we also wanted to represent the magnitude distribution for all the fractions analyzed for our stereotactic group. Looking at both graphics, we can see that most of the magnitudes are low, they are within tolerance, and our workflow is constant without having any significant upward trend. And this kind of consistency is exactly what we aim for, especially in advanced treatments like the stereotactic ones. Now I want to make a special mention to our SGRT implementation in the pediatric treatments. So far, our sample size is fairly small because we are still using closed masks for the pediatric patients, and also we have a fair number of patients that are treated under anesthesia, and that whole setup can get in the way of the monitoring cameras. But overall, even if our sample size is small, our early experience is very positive. We have seen a great improvement in the patient alliance. And I also want to tell you about this nice example of a 10-year-old patient who underwent radiotherapy treatment for soft tissue sarcoma of the lower limb. After he got more used with coming into the radiotherapy treatment, he started to actively participate in the positioning step by adjusting his leg, looking at the line RT screen to make sure that all the deltas are in green. And I think this is a nice example to show that besides the improvement in precision, an align RT can also improve patient engagement, which is especially important for the pediatric cases. In addition to the results I just presented, in this slide I want to tell you about some day-to-day observation from our team. On the benefit side, the Align RT really streamlines the whole treatment process. We noticed a reduced need to repeat CBCTs. Our workflow is a lot faster, and we are able to position the patient correctly from the first try, and also we are able to monitor the patient's surface through the whole course of through the whole treatment delivery, which is very important because we are more sure on our radiotherapy treatments. And we also faced some challenges. Sometimes the camera can be blocked by the gantry when it's at some angles. We also do not have beam control for the DABH patients when we acquire the CBCT imaging, and that makes the RTT to be more focused on the patient and to make sure that if anything happens, they are ready to press the beam off button. And also sometimes we have some issue with the ROI propagation, but overall, even so, we noticed that the line RT has really had a huge positive impact on our overall day-to-day practice. When it comes to patient compliance, almost 60 to 70% of our patients can maintain a stable breath hold, and if they can't due to anxiety or fatigue, they will be safely switched to a free breathing treatment delivery. And an important improvement we also saw by the implementation of SGRT is that our overall patient alignment time has significantly decreased. Now we're able to position the patient within 2 to 4 minutes, with only the first session taking a little bit longer due to the whole preparation process. And with our older title-based workflow, the positioning took about 6 to 8 minutes. And in addition to conclude my results section, I want to also talk about the clinical impact. As I said before, we were not performing the IBH treatment before implementing the Align RT because we felt that we did not have a good way to monitor the patient's breath in real time through the treatment, and by integrating the system, we're able to introduce this technique into our clinic. And for our DIBH group, we also calculated free breathing plans, and we calculated the doses for the heart and the LAD artery. Here I highlighted our dose constraints from our internal protocols, and we can see that most of the DIBH patients that are represented with red were within this tolerance, and most of the free breathing plans have higher dose values. And with the Align RT, we noticed almost 40 to 50% reduction in the overall doses to the heart and LAD, showing a decreased cardiac exposure. These are conclusions. From a quantitative point of view, the system showed excellent setup of accuracy and reproducibility, and most of the shifts were within internal tolerances. From a qualitative point of view, Align RT really streamlines the whole process, and our workflow is overall more efficient. And we also saw a huge improvement in our clinical data with the doses at the heart and the LAD artery. Moving on, we want to expand our use of SGRT for the pediatric patients, and we also want to include more patients in our study. I want to take the team from our radiotherapy department and also the Vision RT team, because without them, we would not have been able to implement this technique into our clinic. And last but not least, I want to take our patients and caregivers, because at the end of the day, they are the reason that we try to constantly improve our daily practice. Thank you.